All right, well, let's go ahead and get started with tonight's very exciting session. Thank you everyone for joining us this evening, and for those of you who are watching later, thank you for tuning in. I'm Koi Fan, and along with my co-hosts Mike Selby and Alex Mamagani and others, we're really excited to welcome Dr. Armen Khachatryan tonight. Out of Utah, Dr. Khachatryan, sorry, Dr. K is
There we go, perfect.
Truly one of the world leaders in terms of arthroplasty. I always enjoy seeing his posts about expanded indications for arthroplasty, and really looking forward to his insights tonight. He's been warned that myself, Alex, Mike may interject from time to time, and we'll certainly also monitor the chat box for any questions you have. So with that, Dr. Khachatryan, thanks so much for joining us tonight.
Well, thank you, Koi, and thank you to everyone at the Global Spine for inviting me to make this presentation. This is a topic that is very close to my heart. I've developed passion for motion preservation arthroplasty around 2006 when I was first introduced to cervical arthroplasty, and ever since then I've kind of felt like this is the direction that I've wanted my practice to move in. So today, as Koi mentioned, I will try to touch upon some of the expanded indications for arthroplasty and kind of what my approach has been through time, and in terms of how that expansion has taken place. It's not something that happened overnight, but over a period of years of practicing and trying to approach it thoughtfully, because obviously every time we do something that may be perhaps pushing the envelope, we're not just doing it in a laboratory setting. We're not just doing it in a type of setting where there's no consequences. There's a patient on the other end of that operating room table that we need to take into consideration. So every one of my kind of excursions into new territory have been in a very intentional and meaningful way. So let's see. So, motion is something that has always made sense to me. And, it's one where, I've always felt that what makes animals different from plants is the ability for us to move. When we look at plants, they cannot move and are anchored to the soil and produce their own food from inorganic materials through photosynthesis, right? So when we look at animals, animals cannot produce their own food. We have to be able to move from one place to another in search of food. Therefore, motion is absolutely essential to life. Motion is not only essential to life, but I also think it is a beautiful part of life. And this is one of my favorite quotes by Aristotle: in all things of nature, there is something of the marvelous. So when we look at this video fluoroscopic image of a two-level cervical arthroplasty, to me, this is so much more appealing than the alternative if this patient were to receive two-level fusion. Those two segments would be dysfunctional and obviously would be moving the stress to the levels above and below. So when we look at anterior cervical surgery, how it evolved in the late 20th century, majority of the surgeries were anterior cervical decompressions and fusions. And when we moved into the early 21st century, arthroplasty kind of became part of our tool chest, but the degree to which arthroplasty was utilized, or in many places still continues to be utilized, is very small compared to the fusion. So if we look at that bigger red circle, if that represents all anterior cervical surgery, only a small portion of it still currently is taken up by cervical arthroplasty. And the reason for that is because when we look at the commonly accepted, or what I call the classic indications for arthroplasty, these are patients with radiculopathy at 1 or 2 levels from C3 to C7. Age range is usually from 20 to 60. No prior surgeries, fusions, instability, or significant facet disease is accepted. Patients should have a reasonable DEXA T-score and their disc height somewhere in a reasonable range, perhaps between 3 to 4 or 5 millimeter height. Anything less than that, many surgeons think that fusion is a better option. So when you look at these indications, most of this came from the arthroplasty studies, whether it's from the ProDisc or the MobiC or the Simplify or the M6. You can pretty much, these were the indications for inclusion into the study, and if patients had anything different, they were normally excluded. So when the FDA approval in the US came for these discs, most of the insurance companies also utilize this as part of their policy guideline as to what they would approve for arthroplasty versus for fusion. So when we look at this example here, this is a patient in their mid-40s with a large right-sided C5-6 disc herniation with fairly well-maintained disc height. So I think for most surgeons who kind of look at both options versus fusion versus arthroplasty, would hopefully look at this patient and say, well, arthroplasty is a reasonable option for this patient. And you can see in this patient, this is, I believe, a year or 2 years post-op, has great motion at that segment, has functional motion, and really should not have any issues related to adjacent segment disease, with the exception of natural aging, right? So then when we kind of look at what have been some of the reasons for limiting arthroplasty, the ones that at least that I've heard over the years as I've traveled and talked about arthroplasty, I've taught many courses. Probably at the top of that list is advanced spondylosis, where the disc is too collapsed. And usually those are the patients that most surgeons look at and go, well, this is going to be a fusion patient. So there's almost no attempt made to even try arthroplasty before using fusion perhaps as a backup. Another common reason is if they look at flexion extension views, if there's limited range of motion or motion is close to being absent, most patients end up with fusion. If the patient has less than neutral or lordotic alignment, perhaps if they got into a bit of kyphosis, another reason that a lot of surgeons feel that arthroplasty may not be a good option. Facet disease is one of those things where we don't really have a good quantifier, so we always talk about things, well, if there's too much facet disease, what that is, well, maybe we can talk about that a little bit when we get to that portion of my presentation. If the patient's bone density is too low, that's another reason that commonly patients end up with a fusion. I still don't know why fusion would be a better option. If you have bad bone density, I guess both can fail, but certainly I believe that there are some tricks that we can talk about, how patients with bone density that is lower than optimal can be used to still give them arthroplasty. Spondylolisthesis, another common criteria. Again, if we stick to Punjabi-White criteria of 3.5 millimeters or less motion from flexion to extension, I still think those patients can receive arthroplasty. So just because they have a slight slip doesn't mean that the fusion is the only way to go. Age is another common parameter. I've heard surgeons say 50 is my cutoff, 60 is my cutoff. But, again, why is that, right? I mean, I think the pathology is more important than the patient's age. I'm in my late 50s. I still want to be able to move my neck around. When I'm in my 70s, I still would love to go and stargaze. So, age should be irrelevant. Levels, again, classic indications 1 to 2 levels. Well, what if patient needs a 3 level? What if they need a skip level? What if they need C7T1? I see absolutely no reason why arthroplasty cannot be utilized in those patients. Patients with prior fusions, we're seeing hundreds and hundreds. We've done millions of fusions over the past years. So those patients are coming back having adjacent segment problems. Again, that is considered to be contraindications for arthroplasty. Once again, I see no reason for that. And then some of the other comorbidities, RA or other autoimmune disease. Certainly in the old days when these patients were receiving, a lot of chronic steroids, it was really affecting their soft tissues and their bone quality. Perhaps, again, that was a risk factor. But nowadays with biologics, there's absolutely no reason why these patients should not receive arthroplasty. A different way I also look at things is what I call the kind of the surgery zones, right? So if a patient comes to me and they need anterior cervical surgery, where do they fit into this surgery zone? Do they fit in more into the fusion zone, or do they fit in more into the disc replacement zone? So, I mean, we're going to kind of through the next set of slides, we're going to look at the green as being the disc replacement zone and fusion as being the red zone. So these are some of the things that I just covered, right? Disc height, range of motion, alignment, facet disease, etc. So now I've kind of broken down on this left-hand side what I consider to be kind of the classic indication. So if you have a disc height between 3 and 6 millimeters, that patient should fall into the green or disc replacement zone. And certainly patients who have less heights, let's say 2 millimeters, 1 millimeter, or perhaps are bone on bone, classically those patients are treated with fusion. Similarly with range of motion, if a patient has less than 2 degrees of range of motion, most surgeons consider that to be close to being so kind of like stuck in and so kind of, immobile that perhaps that patient should be fused anyway because they're almost fused on their own. Again, I think those patients can be remobilized and still receive arthroplasty. And then you can look at the same thing, whether it's as it relates to the alignment with kyphosis. If patients have only mild facet disease, perhaps those patients are going to end up getting arthroplasty versus ones that have moderate or severe disease. tend to be pushed towards fusion. Spondylolisthesis, 0, 1 millimeter. Some surgeons may venture to do arthroplasty, but if it gets to be 2.5 millimeters, 3 millimeters, it seems like they're pushed towards fusion. Classic indication, as far as for most of the studies, was if patients had T-score less than minus 1.5, they were excluded. So similarly, most of the policy guidelines, when we get authorizations for surgery, if the patient has a DEXA score worse than minus 1.5, they get pushed more towards fusion. Age, we talked about this, 20 to 65. I've done arthroplasties in patients who are in their 80s. Extremely happy patients, super appreciative. They're just so thankful when they come back that they didn't have to have a fusion. When we look at the levels, 1 to 2 levels, again, classic, 3 levels, more than 3 levels, C7T1, hybrids, those are all considered to be off-label, and generally those patients end up getting fusions. And again, I mentioned some of the other contraindications that have been classically used, patients with RA, autoimmune disease, or ankylosing spondylitis. I think many of these patients now can potentially receive arthroplasty in the right setting, with the right disc, with the right pathology, right? So, so how can we expand ADR indications? My approach, as I said, has been very, very kind of thoughtful and intentional. And I think if you do the same thing, kind of really think about what is the pathology, what is the problem that you're trying to solve in any given patient, and remain patient during surgery, that is to say, not give up too soon, that is to say, once you run into a problem and not automatically convert to fusion, and use a very, very deliberate kind of a planned approach to the surgery itself. I believe that many, many patients that currently are receiving fusion can receive arthroplasty. And, along with this thoughtful, patient, and deliberate approach, I really think that we have things at our disposal. We have tools, we have techniques that we can utilize, and then really kind of keep at it, practice, practice, practice. And by utilizing these instruments in our tool bag, I really believe that we can expand cervical arthroplasty indications. So in the next couple slides, I'm just going to real briefly show you what is in my tool chest. I have Carling Curiot sets that I use in every single of my cervical arthroplasty patients. I have both forward angle as well as backward angle curettes with starting from O all the way down to 4O, so I can get into from thicker to less thick and really almost bone-on-bone disc spaces and take the disc out, gain access to the posterior aspect of the end plate, where once I can get to the PLL and release the PLL, then by utilizing this next set of tools, which are critical, right? The CastBar distraction pin that you can lock in and utilize it as part of your distraction, as part of your releasing of that disc space is absolutely critical. I really cannot see how, I know there are some surgeons who do the arthroplasty without the CastBar distraction system, but at least the ones that are more advanced pathologies, I really do not see how that's possible. So by utilizing lock CastBar pin and then really this parallel distractor, that is absolutely such a beautiful tool, right? Once I gain access into the disc space and I've reached the PLL and I've released the PLL, this parallel distractor becomes a lifesaver. So this is what I use to release the disc space, and I use the CastBar distraction pin system to then hold that distraction open, that I can complete my decompression and I go on to my next step, right? And this is a tool that I kind of worked on and developed myself, and you can see it's a kind of a crude tool. I took a standard 3/8 inch cob, which is in metric terms is about 9 millimeters or so in its width. And you can see in that lateral profile it's fairly thick, but by using this grinder in my garage, I really thinned it down to almost something that can get into this space that's perhaps 1 millimeter thick, and kind of twist it. And that twist really a lot of times help unlock the disc, so it gives me access to that disc space. So this tool, everyone in my operating room kind of like lovingly calls it the magic cob, because it truly, I feel like it does perform magic when it comes to some of those disc spaces. It also allows me in some of the fat discs, right, to really get between that disc end plate and really take off the disc in very, very swift motion and very quickly do the discectomy. So it's utilized in 2 different fashions, and I'll show some X-rays in terms of how I utilize this tool. And then it's the technique, right? Our goal with anterior cervical surgery, the #1 goal is always good decompression. So that cannot be sacrificed at the expense of motion preservation. So I give that to every surgeon. I always agree with a surgeon that says, well, my goal was to get good decompression, so I had to remove so much bone that perhaps I can't do arthroplasty. It wasn't safe. I had to do fusion. I cannot argue with that. So we always have to get good decompression. But if you can get that good decompression and preserve the weight-bearing surface of the end plates, then the next step, which is the part of the technique, right? The largest footprint, lowest height implant, utilize that, get it to the right spot within the disc space, and you will have successful outcomes. And really all of this comes with patience and perseverance. Finally, the practice. Everyone, or I shouldn't say everyone, most people have probably either read or have heard Malcolm Gladwell's book, The Outliers, and the 10,000-hour practice rule. It turns out that you can't just randomly practice 10,000 hours. You have to have a bit of a deliberate practice. And that deliberate practice has to be intentional, what your goals are, what you're trying to achieve. And with that, whether you're doing music, whether you're doing sports, or whether you're doing something professional like surgery, I really believe that you can improve your outcomes and your abilities. So over the next few slides, I'm going to first start out by really talking about the most common issue that we run into, which is the disc height issue, right? And I'm going to show you some examples as well as my technique in terms of how I approach that disc. And then after that, we can take a brief pause and see if there's perhaps an interest within the audience to talk about any one of these other topics. But first, if you'll indulge me, I'll just cover the next few slides as it relates to the disc height. So here's a patient in her mid-50s, an insurance executive who came to me who had had multiple other opinions and had been told some had told her she needs a 2-level fusion, some had told her that she needs a 3-level fusion because it's a classic scenario where you see C5-6, C6-7 degeneration, and then you see a bit of slip at C4-5. C4-5 becomes a bit hypermobile, right? So in this patient, if you're going to do 2-level fusion, many surgeons will argue perhaps the C4-5 needs to be included in as well, because likely that's going to go bad within a year or two, and then you're going to be back to another fusion. So I told this patient I will do my best to do 2-level arthroplasty, explain to them that perhaps there was a possibility of a fusion as well, but went on to perform this 2-level arthroplasty on that patient. So clearly, what I described in terms of the techniques, the decompression and the plate preservation is absolutely critical to this. Here's this patient, post-operative flexion extension views. You can see very, very good motion of those segments. And then here's the pre-op alignment, right? So there's so many different issues here. There's the 2-level spondylosis, there's the little slip at C4-5, there's a bit of kyphotic posture. And another common question that I get asked, and perhaps we can talk about this a little bit more when we get to the kyphosis portion of my presentation, is like, how do you restore kyphosis? Is there something you do that, kind of gives you that lordosis? This patient that we see on the left-hand side basically has gone into kyphosis because they've lost anterior column height. Our center of rotation for the cervical spine is kind of midline or just behind the center of that disc space. So as we lose that anterior column height, everything falls forward and patients go into kyphosis. So really, what the picture you see on the right-hand side, there was really nothing I did. It wasn't some sort of intentional realignment. It wasn't, if you had to fuse this patient, clearly you would want to fuse it with lordotic implants to get a better alignment. But with this patient, it was all about restoring anterior column height, and you kick that spine back, and you can see the difference between the pre-op versus post-operative Xrays.
Hey, Armen, could I promised I'd interject, so I thought I'd ask you.
Yes, of course.
So, really outstanding result. And is the trick here really all in the magic cob, or did you find you have to drill much for these severe sort of collapsed levels, or because they always teach, don't drill too much with arthroplasty. So
I do not
tackle something like this.
Yeah. No, it's a great question. So you cannot touch the weight-bearing portion of the end plate with a drill. I do not drill the end plate at all. So posteriorly, if you have an osteophyte, something that's along the posterior apophyseal ring, right? There, many times you'll have either a calcified ligament or something that is almost no ligament that exists there, right? So a lot of that posteriorly, I will take it down. I can touch it with a burr, right? But as far as the weight-bearing portion, no, I do not touch the weight-bearing portion at all, because especially as we get into our, patients who have less than optimal bone quality, once you break through that end plate, then your likelihood of having subsidence just becomes quite high. And I think that's how many of the failures take place. But what I'm going to show you in the next few slides is kind of, again, a different patient, but someone who had similarly collapsed disc space, perhaps not as much as far as bone on bone. But there's like literally a step-by-step, kind of, I call it surgery by numbers, like painting by numbers. So here's a patient who came to me. This patient was also, I believe, in their late 40s or early 50s. What appeared to be single level disease, but when you look at the MRI, it wasn't just that C5-6 disc, but this patient also had a very large left-sided C6-7. So this would be two-level arthroplasty. So in this next set of X-rays, I decided for this patient, I'm going to take someone who you look at the pre-op X-ray on the left-hand side and go like, gosh, that's a really collapsed disc space. You have a lot of sclerosis around that end plate, which again is something that helps us, right? When you get that sclerosis, it gives you greater liberty to really kind of distract even harder than you would if you didn't have that sclerotic bone there. So what you see on the left-hand side is a pre-op neutral X-ray. I put the patient on an operating room table. I put a 10 pounds of Holter traction, take a C-arm image, and you can see already just with that, right? Just by putting that 10 pounds of traction, I've already kind of opened up that disc space just enough that it's going to give me that early access, right? The other thing that I'm always very, very careful before I even might start my surgery is I want to make sure they have perfect lateral of my operative level. So if you look at that C5-6 level, my facets are perfectly aligned and I'm seeing a good, clean facet joint. So that's key in terms of making sure that as I go through the steps, that every time I shoot a lateral, my assessments are accurate in terms of sizing and positioning of my trials as well as the actual implant. So the next step on the right-hand side is the CastBar pin that's inserted in there. You can see I usually put it in and I give it maybe 1 or 2 clicks just to give a little bit more distraction. So then another maybe 0.5 millimeter that I've gained just by taking that step. After that, you can see the CastBar pin distraction on the left-hand side. The middle picture shows the magic cob. You know, you put it in there and just give it a little bit of a, like maybe I'd say 25, 30 degree twist. And a lot of times you may hear a crack, and the first few times you think to yourself, oh my gosh, did I just crack the end plate? Well, if you did, you bought yourself a fusion. But really, a lot of times what's happening is you're really releasing those lateral calcified ligaments and perhaps even the posterior ligament, right? And it's okay as long as it's like, if you break the end plate, it becomes quite apparent very quickly because you get excessive bleeding from the end plate. So if you hear a crack, there's no bleeding, you really should be okay. So the next picture on the right-hand side, again, suddenly I've done nothing at this point in time other than, you know, traction, a bit of CastBar distraction, a little bit of a magic cob twist. And you can see we're already, you know, looking quite good. At this point in time, complete the discectomy, get to the PLL, then bring in your parallel distractor, and you can see how powerful this parallel distractor tool is. You really have to get this all the way to the back of the disc space. If you put it in the middle of the disc space, you're either going to create a fish mouth or, again, take the risk of cracking the end plate. So really critical to get all the way back to the disc space or the kind of the posterior edge of that end plate. So you can see now with that parallel distractor, middle picture is what I have after I've finished my parallel distraction. I've held that open with my CastBar distraction pin. At this point in time, I'm going to work on my decompression, go into my foramina, make sure that they're open, they're clean, you know, whatever you need to do with curettes and kerricins. Once I'm completed with that, then you do the trialing. Again, this is a Mobi trial. Once again, I always find that if my facets are perfectly lined up, and I get my trial in, I get perfect circle, I know that everything is aligned. I'm getting an accurate assessment of the depth, of the height, everything looks good. This is the implant that I'm likely going to use in terms of the sizing. So critical issue, right? Before you do your trial, a lot of times, you know, and the other thing that I do is I make sure that my trial gets back to the spot that I want my implant to go in. I never just put in a trial and go like, oh, that looks good, but I haven't achieved the positioning of the trial where my final implant is going to go. And one of the places where I feel like a lot of surgeons get stuck has to do with the uncus. So here's a CT scan that I use for teaching. On the left-hand side, you can see a coronal image, right? With that coronal image taken along the front of the disc space. You can see it along the front of the disc space. You have 18 millimeter width available to you where you can put in an implant. Now you take another coronal image through the back of the disc space, what you see that uncus comes in from both sides, and really the width that you have available is only 14 millimeters. So if we're talking about, let's say, Mobi, or if we talk about ProDisc, right? The smallest width implant that I have is 15 millimeters. So if I don't do something with the uncus, there's no way I'm going to be able to get the implant to its proper position. So it's really critical to really deal with that uncus. Now, early on, I would putz around with a curette and a kerricin and etc. And then I was like, why am I doing this? You know, so I got a very round, 3 millimeter non-aggressive burr tip, a diamond tip. And now I use that all the time to really take the uncus out. So here's let's see a video that should hopefully help us see how that happens. Okay. So again, it's a very, very gentle maneuver, right? You come in, and what we're looking at is that inferior end plate of that disc space. So burr that corner away, irrigate it. So that's kind of, I always come in from the right side. So we're looking at the right side that I just burred. So superiors to the left, inferiors to the right. And then come in again to the other side, flatten that uncus posteriorly. If you do that, then effectively you've taken the disc space that was only 14 millimeters wide, and potentially you can put in a 17 millimeter width disc and get a very, very good end plate coverage. So I think this is one of the critical things that you really need to do before you can go from doing very, very simple discectomies and very simple arthroplasties to more advanced arthroplasties. So once that step is taken, the trial happens. After the trial, I like that trial. I get my implant in. I align my implant. Again, in the case of a Mobi, you align your tabs. You can see everything is just beautifully placed. And one other thing that I do, the difference between the middle and the one on the right is, I tamp that superior end plate just slightly further back. What it does with most of the implants, not all of them, with the Mobi, with ProDisc, it puts that implant in a little bit of a lordotic posture. So it gives me, so that's really the only thing that I do in patients who are a bit flat or kyphotic, that gives me that ability to kick that spine back into a lordotic posture. So that really is, again, that's the first segment. And the second segment, which was the soft large disc herniation. And here's the end result for that patient's spinal lateral as well as spinal AP. So that is literally, I showed you every step that I take to take a disc space that may be, collapse to 1 millimeter or even less than 1 millimeter, and be able to achieve restoration of height and mobilization of the disc space so that I can then do arthroplasty. So again, at this point in time, I'm happy to, yes, of course. That's why.
Armen, may I just please, can you go back to the last X-ray slide from the intro? Thank you very much. There is a question from the chat box, actually from Mike Salby, regarding the release of a segment and the amount of the resection of the uncinate process. There was a publication this week, last week, with complete uncinectomy and still performing cADR, and it worked fine. What is your principle, what to do with the uncinate if you do have to do more foraminal decompression? Is this one of the reasons to go for fusion, intra-op decision? Can you highlight this?
Of course, yes. So, I have actually visited and worked with some surgeons in Europe and in Germany who, with almost every one of their decompressions, they're looking at the vertebral artery. And I don't do that. I'm a bit of a wimp. I almost never want to see the vertebral artery. So I do take down that posterior uncinate, just like you can see in this CT scan image here. And I do it just enough so that it gives me the width that I need, one. And then when I do that, it also gives me very good access into the foramen. So then I kind of enter the foramen with a kerrison, usually, depending how collapsed the space is, but usually with a 2 millimeter kerrison, but sometimes 1.5 millimeter. Once I've entered the foramen, then I try not to reach too far in, because, even though you may have a fairly decent idea how far in, is it 3 millimeters, 4 millimeters, that the vertebral artery may be, I then go in with the right angle curettes that I have. There are 4 curettes that have different reaches. They start with 2 millimeter reach and go all the way to 4 millimeters. And towards the end of my presentation, I do have pictures of those curettes that allows me to do really good foraminal decompression, whether it's a soft disc herniation, whether it's an osteophyte that I'm trying to remove. So I go in there and I feel like very safely I'm able to do my decompression. So going back to your question, if you do a large uncinectomy, right, what does that mean? Can you still do arthroplasty? I think depending how aggressive you are with your uncinectomy, and if you're truly taking down the entire front to back oncovertebral joint, right? So if you're doing a complete uncinectomy, I really think then you have to start thinking about using a disc that is more constrained. I would now do full uncinectomy and use a Mobi. I would do partial or like just enough osteonectomy so that I can have good footprint as well as have adequate access to the foramen so I can do good foraminal decompression. In that case, you can use almost any disc you want. But I think if you're going to be aggressive with your kind of taking down structure that perhaps provides you with some degree of natural stability, then you have to start working with discs that are much more constrained. So then I would kind of move towards a Pro disc or perhaps an M6. And I don't have much experience with Prestige LP, but once again, another disc that does have a bit more built-in stability than does something like Mobi.
And you mentioned that you take the lowest height of the disc, the artificial disc, biggest footprint but lowest height. But if you do indirect foraminotomy by implant height, wouldn't it make sense to use a higher disc? What are your concerns?
Yes. So, well, what ends up happening is that if you take a disc space that's collapsed, that's bone on bone, and you don't take down any of the end plate and achieve height restoration by soft tissue release as well as vertical distraction, right? You have, by getting up to 5 millimeters, which is, even in the case of Simplify, where they say they have 4 millimeter disc, I believe they're closer to 5 rather than 4. So let's say you have to go up to minimum 5 millimeters height to be able to put in a trial and put in a disc. You've already achieved very significant indirect decompression. There's really no need to go to 6 or 7. In fact, in my entire career, and nearly 17 years, I think I've only used one 7 millimeter implant in this humongous Norwegian guy who was like, if I didn't put the 7, it just wasn't going to stay there. That was his normal height. But I've used, I'd say 95% of the time, 5 millimeter height, 5% of the time, 6 millimeter height. So there's really no need to do the fusion type of heights, right? Because in fusions, we go to 7, 8, 9 millimeter heights. But then a lot of times we artificially created that height by taking the end plates down, by removing some of the bone. So if you keep your end plates intact with 5 millimeter height, the amount of indirect decompression you're going to get is going to be more than adequate in terms of restoring some foraminal height, right? We're trying to regain foraminal volume. And I believe that 5 millimeters is more than enough.
This is so important. I love this answer from you. And I just want to mention, I always ask the sales representative, what do the others use? What is your height that you sell the most often? And these are information that are not written in any papers. Quite interesting. The same in XLIF, when you ask what XLIF is used, because everybody uses hyperlordotic cages. But in fact, if you ask the companies, what do you sell the most often? It's astonishing. Low implants, not the high ones.
That's correct. Even with XLIF, right? You're trying to achieve indirect decompression, which is one of the keystones or cornerstones of that technique. And, I really think, again, I have a colleague in the community here who does hundreds. I mean, like he's done probably thousands of XLIFs. And I asked him the same question. He goes like, no, I don't, it's not, obviously, if you take the burr down and create artificial height, you're going to need higher heights. But if you keep those end plates and you want to get good fusion without a lot of subsidence, then you're not going to use very large implants as far as the height is concerned. And the other thing, if you don't take the end plate down and end up putting a 6 or 7 millimeter implant routinely, you're overstuffing that disc, you're putting the soft tissues under too much tension, and those are the ones that you're not going to get very good motion. So clearly the goal is to preserve or restore motion, and if you overstuff it, effectively it becomes kind of a delayed fusion implant, because those are the patients that I think will end up having more issues with higher grade HOs, and perhaps a year or two down the line end up autofusing.
Thank you.
You're so welcome. So again, unless there's a particular request from the audience, I can either run through some of these different scenarios fairly quickly and kind of show you some examples of patients who certainly fell outside of the kind of what is classically considered the green zone for disc arthroplasty. For example, for motion, even most of our fusion studies, right? When you look at the fusion papers, when they were radiographically being evaluated, patients who had less than 2 degrees of motion would be considered to be fused, right? So then by similar kind of, criteria, if you have a patient who's never had surgery and yet they have less than 2 degrees of motion, it seems like that is one of the contraindications for arthroplasty, and many surgeons will favor fusion. So here's a patient, 64-year-old male with two-level disease. You can see that at that C5-6 level, osteophyte anteriorly, some collapse of this space. The level below is pretty much autofused, very large anterior osteophyte, but the disc height looks pretty decent, right? So I get large number of these patients who come to me, and I'd say close to 30% to 40% of my practice are second opinions of patients who've seen other surgeons who've been told they need fusion. You can see there's still really some motion maybe at that bottom level, but really not much. The top level, there I feel like from flexion to extend, there's pretty decent motion. So once again, this patient, I told him, top level most certainly will be arthroplasty. The bottom, we'll see what happens. Can I, when I go in there, can I obtain movement? So the answer was yes. So in this patient, I ended up doing a 2-level pro disc. Here's that same patient postoperatively. And again, I'm showing you the flexion extension views. Look at that bottom level. Look at how much that patient moves now from flexion to extension, right? So this is a 1-year post-op flexion extension view. And we know that the patients who are males, who are older, who happen to have hypertrophic, osteophyte formation preoperatively, those are kind of the higher risk patients for postoperative HO. But again, in this patients, I'll take down their osteophytes, I'll irrigate incredibly well at the end of surgery, I'll bone wax anteriorly, take all the measures that you can to hopefully avoid having that patient develop autofusion. And by 1 year, if you're not seeing significant osteoid formation, you may down the line, but I think the risk is much, much lower. So, you can take a patient, again, whose green zone was from 2 to 11 degrees, perhaps, and you can take someone who has almost no disc space left or no range of motion left, right? And yet be able to restore motion in that patient. If we look at the alignment, right, look at kyphosis, right? Here's a patient, again, has what appears to be single level disease, is not hyperkyphotic, but certainly in a kyphotic posture. Again, you restored that anterior column height. You can kick that patient back into a very, very nice neutral lordotic posture. Here's their pre-op X-rays on the left-hand side. You can see what we have on the right-hand side. There's absolutely no reason why this patient should have a fusion because of that kyphotic alignment. Is there another issue related to the decompression, the amount of end plate that the surgeon had to take down? Sure. But if that is not an issue, the kyphosis itself should not be a disqualifying feature, right? Again, I think some patients who have a really fixed kyphosis, where you get them flexion, extension, you're getting absolutely nothing, you cannot get them to even neutral, I think those are very, very challenging. I've attempted some of those patients as well, especially if it's a lower cervical spine where I'm approaching with arthroplasty, because if you look at your angles, right, if you're doing just the top of the spine, the amount of correction you're going to get clearly is not going to be as much as if you approach the C6-7 or C7-T1 level. You can really kick that spine back into much more neutral or lordotic posture. So facet disease, this is like another really super common, right? So here's a patient who is, excuse me, had a prior fusion at C3-4 level. It's got a little spondy of 4-5. I mean, facets look pretty trashed at that 5-6 level where the pathology is, right? Here's this patient that I performed arthroplasty, again, skip level, hybrid, on so many different levels, it sounds like this should have never been done. But these are both neutral X-rays that you see on the left-hand side, and the one on the right is the pre-op, and you can see at 3 years post-op, this patient has very, very good alignment. And here's that patient's flexion extension view. You can see very good motion at that C5-6 level, 3 years post-op. So I don't think facet disease in of itself is a disqualifier. So this next case I'm super excited to talk about, because this is the one that I posted just this past week to kind of tease people to come to this conference. This is a patient that came to me who'd had 2 prior fusions, right? Had a 2-level fusion that ended up having that C3-4 fused as well. You can see terrible alignment in their neutral X-rays, quite a bit of neck pain. has a spondy at that C5-6, I'm sorry, at that C6-7 level, had pretty poor bone quality. I mean, just like there's so many issues with this patient, right? The only saving grace was the following. Here's the MRI. Her right neuroforamen doesn't look that bad. It's got super tight left-sided foramen. She had pure left C7 radiculopathy and she had very early myelopathic symptoms, but really nothing that I was too concerned about. I wasn't too concerned about at that C2-3 level up top, which if you go back and look at that X-ray, I think at some point in time, that's probably going to be a problem because of that incredibly long plate that's almost in that disc space. So that's going to be a challenge to deal with if that C2-3 becomes a problem. But here's the C6-7 level. So the reason why, again, my approach to this patient was the following. I'm going to go in there. The disc height looks pretty decent. There is a spondy. The facets don't look that great, especially on the left-hand side. You can see that bulky facet on the MRI. So my goal was to go in, do full discectomy, mobilize the segment, but then part of that really had to do with you had to be really careful, you know, in terms of how much PLL I took down. Patient had no right-sided symptoms at all. So in this patient, by the way, before we jump to what we did with surgery, here's the facets on this patient, right? You can see the right C6-7 facet. Does it look great? Absolutely not. The left side, absolutely not. But I still think it's not arthrosis, it's not completely fused. I think these facets can be unloaded and can be mobilized. And some patients may come to you with a fair amount of neck pain and especially off midline pain. This patient was not one of them, so I wasn't too concerned about postoperative facet pain. So here's, again, what you see, the right-hand side, the CT scan, the MRI. Here's the X-ray. So in this patient, I did a couple of things that allow me to kind of achieve this, right? One was I only took the PLL down on the left symptomatic side. So I try to preserve that PLL on the right side because of this patient's somewhat diseased or incompetent facets. So I wanted to preserve as much of their natural kind of structure as possible, right? One. Two, obviously the end plate had to be preserved, but then also you can see on that MRI how there is that posterior encroachment into that canal, right? So Alex, you asked me the question about, you know, lowest height, right? So in most patients, I would put a 5mm implant. In this patient, I went with a 6mm implant because I did want to distract not so much the foramen, but also distract that ligamentum posteriorly to kind of how it's buckled to unbuckle it, right? So kind of all these different problems that were existing with this patient, once again, with kind of thinking about what is my goal and what am I trying to achieve, you kind of come up with a plan, good decompression, preserve the end plates, take only one part of the ligament down, and maybe if you can, go with slightly higher height implants so that you can unbuckle that ligament posteriorly to then get some of that indirect decompression. So this was, again, a case that I shared. But this relates to kind of the topic that I just showed, which is the spondylolisthesis, right? Spondylolisthesis in of itself should not preclude you from doing arthroplasty. Yes, sir.
Armen, this is an amazing X-ray, really, and I loved that you used the keel prosthesis. This is I don't use keel prosthesis any longer. My question is, do you see a difficulty to find the center of rotation if you have a slip situation? In the chat box, there was a question, what do you do when the end plates are not symmetric, if there is incongruent end plate shapes? How do you place your prosthesis ideally? Do you plan it before, or do you think intra-op when you look at the X-ray? This could be the best situation, because I guess you put in the distractor, the CastBar distractor here as well.
Of course. Yeah, the CastBar distractor is almost always, especially in a patient like this one.
We still see the pin on the CAT scan.
That's right. That's right. So what the couple things, right? Going back to your keel comment, and I'll get back to if you have incongruent end plates. Yes, I did use keeled ProDisc in this patient's case because, one, I have a grade 1 slip that we can see preoperatively. Two, I have a huge lever arm above it, right, with Twolevel fusion. So I mean, like, when you think about all the kind of negatives or all the kind of issues that you have to deal with, or the patient postoperatively has to deal with, right? And what we're asking the prosthesis to do, really, I can't think of another implant that can perform in this patient better, at least the ones that I have available to me in the US, right? Perhaps there are some others globally that can also perform similarly. But I think in this patient's case, with that huge level arm, the Pro Disc with a keel, giving me the best possible fixation, especially in a patient with suboptimal bone, was the right choice. And again, that was part of the planning, right? You have to kind of think about what prosthesis I'm going to use. In terms of incongruent end plates, once again, I believe an implant that has a fixed center rotation, such as Pro Disc C, is the only way you can get some degree of reduction or kind of reestablishment of congruence between the end plates. If I put a Mobi-C in this patient, again, a disc that I use very, very commonly, right? What's going to happen with the mobile core? If you have the two end plates that are not congruent, if one has slipped against the other, that core is going to do absolutely nothing, even if I have a good X-ray intraoperatively, right? Once the patient gets up, the core will float forward and the patient will fall forward. Versus with a fixed center of rotation, which is what a Pro Disc C is. It's got a the motion for this disc is basically an arc. It's not, has no translational motion, it's an arc. So what I do in this patient, I get my bottom end plate to the position where I want it. And then I take my top end plate, because when you're inserting it, they come in block, right? So they'll go in almost parallel to each other, and then the back of the end plates will be flush against each other. But you can see in that image in the left-hand side, how the top implant has been kicked back, right? Or the top end plate has been kicked back. And that part of it is what allows me to reduce that grade 1 spondy back to where it aligns much better.
So it's great to learn from you, and I think it shows really clear that the cADR is much more difficult to plan, and you've got many more things to consider than a simple fusion.
And then I would argue, Alex, in this patient, right, even let's say I said, okay, I'm going to do fusion. I mean, think about, you have 3 levels fused up above it. So if I go in at C6-7 in a patient who has poor bone quality, I put do my decompression, however you do it, right? And then do fusion with the best possible plate. I don't care what plate we use, right? What are the odds that this patient is going to fail with a fusion? I think it's quite high, of hardware failure, screws pulling out, something happening, the implant subsiding, right? So if that either happens, or if you want to prevent that from happening, what do we have to do? You have to flip that patient, you have to instrument that posteriorly, and likely for most patients who you're doing this exact scenario, they end up instrumenting all the way down T1 or T2, right? So then suddenly you've taken a patient who's already has really bad loss of motion, obviously from the 3 levels that have been fused. You can see that C2-3 is going to likely have some problem because of how terribly that plate was placed. And you end up with a patient with C2 to T2 fusion. So that's a big difference between that and a patient who unfortunately had a 3-level fusion. But I hope, again, obviously, it's too early to celebrate. This was only a week and a half ago when I did this surgery. But when this patient comes back, I can't wait to see this patient back for their first pre-op visit.
Yeah, thank you. I absolutely agree that doing a posterior fusion, even if posterior is native and there's no posterior fusion before, and anterior, you're struggling with a scar as well, and maybe you hurt the ESO. I don't know. There are so many pitfalls in this going from anterior and from posterior. It's really, please post your results and we can follow your case.
I will. I would love to. When I see him, I will. I promise I will. And again, I felt that, yes, this is, I think some surgeons may criticize me for doing this. This is absolutely crazy. Look at this 3-level fusion. Why would you even think about this? But I really believe that this is a lower risk for failure. I'm not saying it can't fail. Obviously, we all know anything can fail, but I really think that this is a lower risk for failure than would be to do just a standalone anterior fusion. And certainly if you felt that that risk was too high for failure, then those patients are going to end up with, you have to flip them over and do what I consider to be most painful spine surgery that I ever do, which is posterior cervical instrumentation. I mean, the amount of muscle stripping and dissection you do for that is just I think, as I said, those are the patients who have tremendous amount of post-op pain. Even if you have solid fusion, they just complain a lot of scarring and muscular pain, at least when you do it open. Perhaps if it's done kind of in an MIS fashion with navigation, perhaps that's less so. So that again, I think the spondylolisthesis envelope can be stretched, and I believe that certainly requires quite a bit of planning and understanding to be able to do so, but it can be done. So when it comes to bone density, here's the trick that I kind of, when I was in college, I had a lot of friends who like to break into things. I went to a nerdy college where there were a lot of hackers and there were a lot of people who like to pick locks. So I always felt like when I came out of college, whenever I saw a difficult problem, I always thought to myself, what is my hack? How can I hack this problem, right? So, there's an 83-year-old female with two-level disc degenerative spine, as well as severe bilateral stenosis, T-score of -2.9. What happens with this patient is the following. So if we look at their pre-op X-rays, again, nature takes away from us with the osteoporotic cancellous bone. But in most of these patients, what I find with their spondylosis, they end up also getting a fair amount of sclerotic end plate. So even though the middle part, right, of that vertebral body is incredibly weak, the end plates are still in pretty decent shape. In fact, they might be better than normal, right? So in these patients, it is absolutely crucial. It is absolutely crucial that as you do your decompression, you just cannot touch the end plate. Take whatever disc you want to take out, take the PLL down, but the end plates have to be preserved. So in osteoporotic patients, usually you see those in patients who are in their 60s, 70s, 80s, whatever that may be. Many of those patients do also have good sclerotic end plate. I think the most challenging patient who has poor bone quality and is osteoporotic would be someone who is, let's say, has had total hysterectomy and had that menopause in their 30s, and perhaps comes to you in their mid to late 40s with very poor bone quality, but no sclerotic bone. That patient, to me, becomes very, very challenging one to treat, because I think the risks of subsidence in that patient becomes quite high. So this is that same patient 12 months out, post-op flexion extension views you can see here. So again, I don't think osteoporosis per se. What I've seen now with the latest Synergy study, they're including patients up to a T-score of -2.5, which I'm very, very happy to see. But I think you can even push that a little bit further on that kind of, on this green versus red zone, perhaps -3. I think once you get above that, you're really, it's almost like no matter what you do, the chances of failure is quite high. And then I guess we're coming, we have only 6 more minutes left. I'm happy to, again, age, absolutely irrelevant to me. Here's a 77-year-old male, two-level disease, did a two-level pro disc. Here's a 76-year-old retired dentist came to me. You can see on the right-hand side his pre-op X-rays, the pre-op CT, intra-op, two-level M6, 3 weeks, 6 weeks post-op. So this was not too long ago when I did this patient, so I'm waiting to see him back 6 months post-op. Yeah, so 1 year post-op should hopefully come up soon. Age is not a problem. As far as levels, again, here's this patient was in his 50s, 58-year-old male, 3-level disease. Here's that same patient's 4-year post-op. So this was one of my first 3-level discs that I did. And you can see at 4 years post-op, this patient still has very, very good motion. Everyone knows segments. This patient, again, came to me, towards the end of March of 2022. Here's another patient, 62-year-old with 3-level disease with Mobi. Here's the flexion extension views post-op. 59-year-old male with 4-level disease. And again, this is, again, much, much more challenging in terms of the pathology that we're dealing with. This patient ended up with a 4-level Mobi C. Here's the post-op, 1 year. I believe I have flexion extension. Nope, I didn't have the flexion extension on that. Here's a 51-year-old male, 2 years after a C5-6 ADR came to me. Look at that CT myelogram, had a C7-T1, a right C8 predict. So this was a skip level that I performed. Again, there was absolutely no problem at 6-7. So why touch it? Leave them with their natural disc. Here's the post-op flexion extension views, both segments moving very, very well. So again, levels, whether it's C7, T1, whether it's a skip level, whether it's more than 2 levels, it becomes a little bit more challenging. Obviously, the positioning becomes much more critical. You have more room for error if you're doing a 1 or 2 level, but once you get up above that, really properly sizing, properly positioning within that disc space becomes much more critical. Prior fusions, here's a patient with prior 2-level fusion, had a 2-level problem up at the level up above, 2 years post-op with a Mobi. Again, I tend to use Mobi much more so in upper cervical spine, even next to hybrids. I have no problem with that. If this patient had a problem below it, I'd likely use a ProDisc C. With Mobi, you don't have to worry about the plate. You don't have to worry about the key cutting the keels. But with ProDisc, you do. Here's another fifth. So that was a secondary hybrid. This is a primary hybrid. Patient with 4-level problem, ended up with 3 of them, arthroplasty, and 1 of them with a fusion. Again, if I do this, I always look at it, what am I doing to reduce my fusion burden? I kind of think of the fusion as a burden on the patient's functionality. So even with something like this, I'm okay if I have to sacrifice 1 level. And the level that I sacrifice, if you look at it, is the one that has myelomalacia, is incredibly tight. Again, I felt like that the decompression at that level was much more critical than the motion preservation. So I really took a lot of the posterior end plate down. And I felt that in that case, fusing that level was a better way to go than, again, giving that 1 extra level of motion. So another 68-year-old female. This is one that I did recently with the left-sided pathology. Again, a ProDisc at the level below. You can see in this patient, I had to cut the plate because the plate was so close to that level. So instead of exposing all the way to the top, I guess you can do that and take the whole plate out. I just cut the plate and then did the arthroplasty. And this patient recently came back for a 6-month post-op visit. You can see her flexion extension views. Not amazing motion, but certainly very good one. So, and then I think, gosh, very last one, I think we're gonna maybe even make it. So I love this patient. This is one of my favorite patients I've ever treated, 45-year-old female, ex-gymnast, a tiny lady. She was like 5'1", very fit, 2-level disease, had RA. I checked her bone density, very good bone density. So absolutely no reason why I can't do arthroplasty. Here's her C5-6, her C6-7. Did a 2-level arthroplasty, did amazing, right? Comes back a couple years later with myelopathy, with this huge disc be up above. So again, we know with RA patients, they have poor tissue quality, even if they may have a good bone quality. So this patient, I took her back to the OR, and I was going to do arthroplasty at both levels, but the reason why I didn't do arthroplasty at that C3-4, she was so tiny that the smallest implant, which is 15 by 13 footprint, there's no way I could fit it in there. So I ended up using that top level. So she has sent me so many patients. She's, as I said, delightful patient. So those are this is kind of the circle that I showed you at the beginning. This is what happened when I started, and this is kind of what's become. Over 90% of what I do in the anterior cervical spine now is arthroplasty. So I've enlarged that green circle by just really kind of keeping at it. So again, thank you so much, and I'm happy to take any more questions if there are any.
Thank you, Armen. This was wonderful. Thank you very much for your presentation. So there are some questions from the chat box regarding the image quality in post-op MRI, whether it's different between the different types. Do you do a lot of CT myelo now, since you do so many TDRs, or is the quality of MRI still acceptable for you?
Yes, that's a great question. So the good news is that, unfortunately, we really don't have to do that many post-op imaging at the level of the pathology, right? Because I find that the success rate, if you've done like adequate decompression, is incredibly high, right? Occasionally, if you have to image it, usually it has to do with adjacent segment problems, which there's almost really no disc that doesn't allow you to see the adjacent segments. But if you have to visualize the level, the operative level, and in patients who are myelopathic and have myelomalacia, and I really want to be able to postoperatively image them, I have migrated towards, I didn't show any examples, but I do use Simplify in that case, because with Simplify, you get unbelievably good imaging postoperatively at the level of the surgery. With some of the other implants, if I were to kind of put them in order, which one gives us the best MRI images? No question, Simplify is number one on that list. I don't have much experience with Prestige LP, but I understand that has a favorable footprint. Then next after that would be M6, has because of its titanium metal end plates, has very good. Then the next after that would be MobiC, and then I think probably the worst footprint MRI is the legacy non-titanium ProDisc C, right? Because in US, even the Vivo and the SK that we now have is not, it's cobalt chrome. I understand that outside of US, some of those implants are now in titanium format. So, but there's the metal suppression protocols that those are software protocols that allow us to suppress the metal artifact, so you can see at the operative level. And in many cases, depending on the quality of the MRI, you can see in the foramen at the operative level, even with something like an M6 or MobiC quite well. So, but as I said, the good news is that we're not imaging these patients very frequently postoperatively. If you're truly, truly concerned about the operative level and you cannot see on the MRI, then yes, the imaging choice becomes CT myelogram, which, you know, we don't want to use that very frequently, but if you have to, I don't think it's an issue.
Thank you. Armen, last question. When we will raise our percentage of TDRs, which is the most common complication when you look back you had, and you would give us the tip to prevent? What is your most valuable recommendation for us when we do more and more TDRs?
Gosh, that's a really good question. I think, you know, there was a period of time up until about 2019 that every time I would do my presentations, people would ask me like, well, how often do you do revisions? And I felt unbelievably uncomfortable and self-conscious to tell some of these surgeons, I haven't done any revisions. And because like any surgeon who says they have no revisions of their own cases, your first instinct is like, that's absolute bullshit. So, and it was true, I had not done any revisions up until 2019. And I think part of it had to do was I was incredibly careful in my approach to expanding my indication. So for a long, long time, I stuck in the kind of within the guardrails, right? So that's where kind of I got most of my practice. And I feel like if you stay in that zone for a while and get 100, 200, 300 cases under your belt, the likelihood that you can have any type of complication other than the common stuff of dysphagia, dysphonia, etc., some postoperative swelling, etc., right? But in terms of like ones that require a possibility of revision or further intervention, like posterior foramen anatomy or something like that, I think is incredibly low as long as you kind of hone your skills in that zone, right? And then slowly, very, very slowly start tackling one problem at a time. The case that I showed was spondy with a fusion above it, with poor bone quality. I mean, that should not be a case that a surgeon who has only done 10 or 20 or 50 arthroplasties to tackle, because I think the likelihood of failure on that is going to be quite high. So some of the revisions that I've done have been where it was, you know, I've done one revision where it was a simple C5-6 ADR. Patient continued to have very severe, you know, C6 radicular pain. We tried everything, did a select nerve block, pain went away. On the MRI, I could see maybe a trace of something. I did a posterior foramen anatomy on that patient. Yeah, I guess I'd left a little disc fragment behind, took it out, closed them up, woke up, pain was gone. So I think if our approach is methodical and careful and, you know, like what I said at the beginning of my presentation, being patient, I think arthroplasty, when we look at every clinical trial, and granted, the critique is that these are industry sponsored, but I've been in many clinical trials and the amount of scrutiny these trials get from the FDA is unbelievable. So with that kind of in the background and in our minds, with every ID trial that I've been involved in, revision and reoperation rates with arthroplasty is anywhere from 2 to 3 to 4 times less than it is with fusion. And the number one mode of failure for fusion is at the index level, symptomatic non-union or pseudoarthrosis. At the adjacent level, it's adjacent level decompensation, which we start seeing at 2, 3, 4 years out. So I think overall with arthroplasty, it's not so much is there something that I can tell you that's gonna make improve your odds. I think what I can tell you is just kind of keep at it and really get a lot of practice, what I call in basketball, I don't know what it is in soccer, but in basketball, doing the layups, right? Do a lot of layups, and then after that, start doing free throws, and then, wait till you start hitting those 3-pointers.
Thank you very much. This was so interesting. I learned so much from you, and I think I may sum this session up that Dr. Khachatryan knows the world behind the discussion of whether we should do one level ACDF or one level TDR. You showed us today very nice cases that we can have good solutions in the difficult, in the challenging cases as well.
Well, so, thank you. It's been my pleasure.
Next week, we will announce the next talk next week on social media as usual, or I don't know whether Dr. Vaj knows what the topic next year. Thank you very much for joining us tonight, and thank you, Dr. Khachatryan. Thank you, Armen, so much for your amazing presentation.
Okay, bye-bye.
Thank you, Armen. That was great. Thank you.
My pleasure.